Just quick question, a quick aside. Richard, how many of your patients with suspected HCC?
Yeah, it is still a minority, I think, because, there's suspected and diagnostic, right?
Yeah.
And for someone who is clearly cirrhotic with a LIRADS-5 lesion, hypervascular with washout in the right clinical setting, generally we do not biopsy them. Now, with that being said, for patients who go for ablation, the radiologists do tend to do a biopsy at the time of ablation, just by practice pattern. There are patients in the context of research studies now which do want tissue for either biomarkers or confirmation of diagnosis. But I think the majority are not being biopsied outside of those scenarios. And Julius brings up an excellent point in many ways. How much of liver cancer progress has been delayed by the lack of tissue available? And I think there's two ways that we think about that. One is to understand tumor biology and identify new targets or approaches for treatment. The other part of that, which is increasingly important, is linking, some biomarker in a biopsy to a therapeutic, right? A predictive marker, right? Which we lack dramatically in liver cancer. I mean, the only drug that is associated with a predictive marker of benefit is AFP, and that's for ramucirumab in the second-line setting. But no other drugs have really been developed with a companion diagnostic. That's the term we use in medical oncology. Something that you need to test, whether positive or negative, tells you how to treat patients. And that is really an important part of our mission in cancer medicine and getting the right drug to the right patients, especially now that we have several choices that all have positive data. How do we decide which is best for the patient in front of us? And that's an ongoing translational effort.
Julius, I saw you nodding your head for part of this. Anything to add as far as from the biopsy component, biopsy question?
Yeah, well, I mean, obviously, as a scientist who's trying to develop biomarkers and thinking about molecular imaging or, even machine learning approaches and how to identify what kind of tumor we're dealing with and whether or not this is sort of like an immunologically hot disease or whether or not this even is going to be predictive for a good response to immunotherapy or which particular drug. I think, I understand when someone tells me that biopsy is going to be risky or, there is a risk of seeding, which I think is more or less theoretical. And even some IRs will say, like, if you biopsy a tumor and then you have to do an embolization, then you're going to create possibly a shunt or a fistula. I just feel as though, we've probably missed an opportunity to investigate this cancer better. I think I'm discovering and understanding the system more with the years that I do research on these patients. I think that the resected samples are a great treasure for us to really better understand. I mean, although most of these patients don't undergo immunotherapy before, but some now have. And I think that those samples are going to be more and more important for us to understand really what is going on in these tumors.
Just for the discussion, because like you, I have no fear that biopsy is dangerous in these patients. I know experienced IRs can do this. There's no real risk of seeding. You burn the tract, you go through a cannula. I guess the issue is, LIRADS is, when you have a LIRADS-5 lesion in the right patient, it's pretty diagnostic, right? That's been the challenge to overcome for us, I think, right? You've done yourselves very good at radiology, better imaging, better protocols. And then it's like, well, now we don't need to do it because we need tissue. But I agree, biopsies are really important for us to move forward.